From selecting the perfect phaco fellowships to navigating the intricacies of cataract fellowship expectations, we have got it covered up. So, learn how to conquer the challenges, overcome the mental hurdles, elevate your surgical powers through the dynamic discussions, experts' insights, and the invaluable patient experiences. So, unleash your potential and chart a course towards a surgical excellence. So, for all those who are here, who are young surgeons, who want to become expert surgeons, I think this IC is a must to know how you can excel, how you can opt, and what all to expect during a fellowship. So, for our first talk is crafting your fellowship journey, how to choose the right phaco fellowships by Dr. Anne Teresa Anthony. She is currently a consultant phaco surgeon working at Amita Eye Care, Tiruvalla. Welcome. And you can start.
Thank you, Dr. Raki. Over the next few minutes, I'll be highlighting certain crucial factors that will definitely help in the roadmap of a successful phaco surgeon. So, this is what happens at the end of my residency, your residency, and everyone's residency. You are the jack of all trades, but the master of none. And this makes the fellowship a necessity. And these are the struggles we go through post residency. Every institute now requires a ophthalmologist with a fellowship. And if you apply to a training center, there will be a long waiting list. And for females, there will be a lot of pressure from the family to settle down with marriage and children. And this is a time you will be struggling with work life balance and financial pressure. So, with that in mind, at the end of 5.5 years of MBBS and 3 years of post graduation, you all will be standing at this crossroads thinking, should I go for a fellowship again? Before choosing any fellowship, weigh the pros and cons of each subspecialty. Find out what is your passion and what kind of job gives you the most satisfaction, because this is what you will be going to do in the next 30 years of your career. And always find out the job requirements in the area where you want to settle down. And always ask yourself that after undergoing this concerned fellowship, can I become a competent practitioner in that area? Choosing cataract as subspecialty is really rewarding for a number of reasons. Obviously, we have a wider pool of patients and it's a gratifying specialty because it gives 6 by 6 vision to the patient the very next day of post-op, and the smiling face of patient is highly rewarding for the surgeon. There are unlimited job opportunities with a good pay right from the beginning, and a lot of vacancies are open in both rural and metro cities compared to other specialty. So, why there is need for phaco training? Phacoemulsification, which has become the gold standard of cataract surgery, and surgical proficiency in phacoemulsification is a most mandatory core competency for the modern cataract surgeon now. And now we are moving to the era of refractive surgery. And in the present scenario, there are a lot of expectation from the patient, like we need a eagle vision immediately after the surgery. But if we look into the surgical training of the residents in India, it's not keeping in pace with this situation. So it's always important to understand the ground realities from a resident perspective. Residents most of the time are exposed to limited surgical volume and they hardly get their turn once in a week and never get to do the wet labs. So the high stress environment and all the difference in this curriculum make residency a bad destination for making a proficient in-house cataract surgeon. And when you ask for phaco exposure during residency, this is what happens. An anonymous online survey was conducted among the ophthalmology residents of India, and the result from the survey showed that majority of the residents are getting good number of SICS, but when it comes to phacoemulsification, the exposure is very limited. And if we look what is happening in Western countries, the data from the European board showed that the self-confidence level to perform a case post-residency was rated only 4.1. And all these data shows the need for an appropriate training. And during the transition phase, that is when we are just into the fellowship, what we all need to change is the mindset before the actual learning. So most of us in the beginning stage has a common question in mind. Are the surgeon born great? And we often hear from our colleagues that this surgeon has got great hands. Is this really true? These kinds of thoughts are quite disheartening and for a lot of people, especially for those who have lack of self-belief. Surgeon born great is a myth. Surgeons are actually made with structured and appropriate training. This clarity of thought is required before joining any training program. And where to choose the fellowship? Obviously, everyone will be looking for a place with good numbers, good pay, and comfort zone. But in reality, this triad doesn't exist together. From a surgeon's perspective, what is more important is getting good surgical number. So you have to sacrifice the other part to get a good surgical number. The next question, whether to go for a short term or long term. It all depends upon how you were trained during your residency. Short term fellowship will be beneficial for those who are well versed with the SICS skills, like who are good in capsulorhexis, and obviously it opened windows to other subspecialty. Long term will be beneficial for those who had inadequate exposure to SICS and who needs cataract subspecialty as a career, and you will get a lot of opportunities to manage the complication. So, be wise while choosing an institute. See for the faculty available for training, because Arjuna was defined by Dronacharya. And choose an institute with a good infrastructure. It's always better to go for observership and visit their OT just before joining the institute. Ensure that they have a well structured academic program and always talk to the ex fellows and inquire about the hands on experience they had. Make sure the institute has a good wet lab. Go to the institute where they teaches you even the minutest steps sequentially and systematically. That is from basics to SICS to Phaco and to manage the complex cases. Always prefer an institute with research and publication opportunities, and an institute with posterior backup segment is always preferable. So the list of institute is endless. You can avail the data from AOS website. YOC help this is really helpful. So with a right mindset and with a structured training, you all can become a competent phaco surgeon. Thank you.
Thank you, Dr. Ann. That was a wonderful talk with great insights. So, moving on to our next talk, which is maximizing the fellowship outcomes and what to really expect from phaco fellowships, by Dr. Reshmi S., who is a consultant phaco surgeon at Eye Foundation, Calicut.
Good morning, all of you. As Dr. Ann has already described how to choose a right phaco fellowship, I will be talking about how to maximize the outcome from your phaco fellowship. So whether you select a short-term fellowship or a long-term fellowship, it's going to be a tough time. So you have to provide your maximum dedication and hard work so that you can overcome the hurdles easily. There is a learning curve for all these procedures. Some surgeons may not be able to overcome the initial frustration barrier and they become dropout. Some people will overcome this frustration barrier. They learn the surgical steps to become a competent surgeon, but they keep on doing what they learned during the residency period. They don't go for experiments and they don't enjoy tough cases. There is a third set of surgeons who will overcome this passion barrier. They find enjoyment in doing tough cases and they learn from each and every case they do. They become the expert surgeons. So what we are going to discuss here is how to learn during the fellowship period, how to maintain the logbook, what about wet lab training and AA based learning, how to handle complications, what after fellowship, what are the qualities to gain, and few tips. So how to learn during the training period. In the initial period of your training, choose only the right case. Perfect each step properly so that you can move on to the next step with confidence. Discuss your problems with your colleagues. They may also face the same issues, and think and discuss how they overcome their problems. Learn to stay calm during complications and learn to break the bad news. The slogan for the fellowship period is observe, observe, observe and learn. Record and watch your own surgeries as far as possible and you can be your best teacher. During the training period, gain a good idea of phaco-dynamics, phaco-fluidics, know your phaco machine and the microscope settings. You should get good control of your hand movements, right and left, perfect your wound architecture, identify and manage complications. It is always better to have complications in your training period than to have them during the independent practice. Whenever you have a problem, ask for help or convert to SICS. Don't blame your ego. It is always better to maintain a logbook for your cases. In that, you can record the preoperative findings, intraoperative steps and some problems which you had, and you can also note down the tips which you can take down to decrease the problems in the next cases. Wet lab is a very essential part of any training program. Wet lab helps us to learn the surgical anatomy of the eye, practice the surgical steps properly, learn the intraoperative complications and their management. It helps us to handle the surgical instruments, develop hand-eye coordination and practice steps. In the gut eye, we can learn the sclerocorneal tunnel, capsular access and hydrodissection. The polyurethane foam sheet that comes with the suture material can be used to practice suturing as well as sclerocorneal tunnel. The polythene film that comes with the IOL packaging can be used to learn capsular access also. Nowadays, we have these AI-based learning platforms also. One is the Alcon Experience Academy and the other one is the Size Surgery Optimizer. These are mobile applications which you can download from the Android or the App Store. With these applications, we can view the surgical videos of eminent surgeons, even step-by-step videos they are providing, and we can learn from that. Complication handling is a very essential part of the fellowship program. Two things we have to take care. One is the intraoperative decision making and the second part is handling of the patient. Intraoperative decision making in crisis situation is very important. We should have a game plan ready for each and every complication like PCR and nucleus drop. The second point is dealing with the patient. We should have ready-made phrases with us. Don't be clumsy while communicating with the patient and they may think that we are not confident. We can say that the cataract couldn't be removed as it was not accessible or the membrane was not strong enough to hold IOL, etc. Always give further management options like the VR surgery and have a definitive plan for such patients. Near fellowship period, sometimes you may have this burnout syndrome. It is characterized by emotional exhaustion, depersonalization and a sense of low personal accomplishment. It is seen in 60% of the fellows and trainees. If you face this at any point of time, don't be reluctant to ask for help. You will have complication, you will get scolding, you will get punishment, everything can happen. But never give up. You may feel worthless, but never think that I can't make it. Never compare yourself with others because everyone has different potentials. Compare yourself with whom you were yesterday and try to improve each day. Become independent, self-motivated and self-directed. Believe in yourself and you are halfway there. So what after fellowship? You may go for independent practice or a group practice. Whatever you do, select good patients and good cases initially, spend enough chair time with them, slowly take up challenging cases and thus develop your career. There is a concept that the surgeon's hands are the blessed hands. That's not true. Surgery is done with the mind and not with the hand. Great surgeons must have equipped his mind to anticipate, plan, analyze and implement appropriate thing at the right time. So, the qualities to be gained during the fellowship period is a good surgical judgment, that is very important. Good dexterity is needed, intelligence, knowledge, creativity, courage, perseverance and most importantly mind training. Surgeons are not born great, they are just made great. So the tips for improvement include set appropriate goals during the training period, create a timeline and evaluate your progress periodically, develop essential skills, do the pre-work before each day training session so that you can improve daily, build strong relationship with other fellows, develop critical thinking, read more, attend conferences and identify areas of improvement. So above all, attitude is everything and never consider yourself as an expert. Thank you.
Thank you, Dr. Rashmi, for those motivating talk. Now I request Dr. Raki Dikruz, our dynamic speaker, who's a consultant phacosurgeon at Chaitanya Institute, Kollam, for the topic Mindset Mastery, Delivering Bad News, Staying Calm to Surgical Complication. Over to you, Dr. Raki.
Thank you. So, good morning everyone. I'm Dr. Raki and I'll be talking on how to deliver bad news and staying calm through surgical complications in your initial period of your career. So, practicing ophthalmology is exhilarating and fulfilling when you are able to help the patients recover their vision. But there will be times when you need to tell your patient some negative information about their prognosis or about their surgery. So are we really prepared to be the bearer of this bad news? So I think nowadays there are a lot of legal cases going on with surgeons. This has become because the people feel like we are money buggers. And also I think one of the major problem here is the young surgeons lack communication skills like the older surgeons. So we need to upgrade our communication skills with the patient. And most of these things can be cured if we have a proper preoperative chair time. A good preoperative counseling can save us from a lot of issues. So whenever you are taking up challenging cases, or maybe it is just a regular case also, just try to detail about all the possible complications, giving small examples. You see, 5 in 10, 100 patients can have this. A 2% of patients can have this, like this. But try to tell what are complications that can happen in your initial period of career, however confident you are. But after counseling, you don't need to scare them off also, right? So reassure them by explaining that this is just a common set of complications that we explain as a common standard protocol to all the patients, because we are not gods, right? And we cannot predict every outcome. However, as a doctor, you are confident and you can guarantee to give your utmost best care to this patient. So if you can convert this to Malayalam and tell this to every patient, you are saved. Second, the complication has happened. So you need to prepare first before breaking the bad news. First, know your patient's background, their support system, who is going to take care of them, their financial system. Consider the emotional state, educational background, and their level of understanding. When you are delivering the bad news, you should maintain a confident body language, maintain proper eye contact. You should not be having any nervous gestures, and be very assertive while talking. So there are a set of protocols that are being set up by doctors itself. This is a SPIKES protocol set up by the doctors in the oncological field, which stands for setting, perception, invitation, knowledge, emotion, and strategy. Setting means you need to find a comfortable time, a private warm space, set the meeting with your patient and bystander. It's not necessary to rush the news like dropping a bomb. First, take a moment or two to connect with the patient and as well as with the bystanders. Whether we understand it or not, this decision is going to change the patient's life. Perception refers to the patient's current level of knowledge and assess whether the patient already knows or suspects by overhear something from the OT. Invitation is asking the patient if they want to hear the detail about the situation. If they want, you can explain. If they don't want, don't force them. Never over-explain. Knowledge is your own knowledge on how to share the news clearly as well as compassionately. Avoid using vague languages and lot of medical languages because this can create confusion. Emotions is acknowledging the valid and validating the patient's feeling. Create a space for the patient to express their emotions, and for this you need to practice deep empathy. Put yourself in their shoes first, identify their reaction. It can be sadness, it can be anger, it can be shock, it can be denial. But help them in identifying that too. Now, come up with the last segment, strategy. Discuss the next steps and the care plans. After delivering the bad news, offer the steps or support that you can help to ease the tension. It shows that you care and you are willing to help. Come up with the follow-up plan of what all surgeries that might be required further, what is the financial needs that might be there, and what are the aids that you are going to provide. So, staying calm through surgical complications is the second part. Complications, as we all know, are inevitable. We evolve and learn from our mistakes and complications. But then what to do when you have complications, especially in your initial period? First of all, accept the complications. Stop denying. So this has happened to me also in the initial period. I know my gut feeling says I made a PC run, but still I'll be thinking, no, I don't think there is a PC run. Let me just put the IOL and see. So now I have stopped that. Yes, now I accept I made a complication. Everybody does. Great surgeons also have complications. But I am going to handle it in the best way possible by myself. Be mindful of the situation. Concentrate, compose, stop being anxious. Give yourself a minute or two. Take few deep breaths. Think of a recovery plan. This will minimize further mistakes or iatrogenic complications from your side. Never abandon these patients and be very empathetic and considerate to their situation and get help from your colleagues. Maybe you can get help from your VA colleague to do the best for this patient. So, staying calm through complications is very easy to say, but it's not that easy when it comes to real life, right? So, for this, you need to practice something. You need to practice breathing techniques, practice mindfulness or yoga. You need to control your emotion. So, I will just take a minute more. So, here, how to practice mindfulness, especially in your OT days. What you can do is in the morning or just before the OT, just spare 5 to 10 minutes for this. Take a comfortable seat wherever you can find a comfortable seat. You don't need to have a very comfy seat and all. Maybe it's just your regular consultant seat is also fine. But set a time limit. Nobody else should enter during that time. Notice your body. Just be calm. Concentrate on your breathing, on your inhalation and exhalation. And in between, the mind keep wandering. But whatever it is, be kind to that wandering mind and try to bring it back. Just do this, concentrate only on your breathing and nothing else. For 5 to 10 minutes, your mind will calm down. Just before your OT, you'll be having a very stress-free mind. And this is the last slide, and this happens to the new surgeons. They get caught in the spider web of complication. And why does this happen? Just remember, whatever complication has happened, you have your next cases waiting for you. You cannot abandon them. Compose yourself. After you finish that complicated case, stop thinking about what has gone wrong. Remember, you can't change anything by blaming yourself for being guilty. What has happened has happened. You need to refocus. Give your 100% concentration in your next case. Get your mind back in your OT. After the OT, try to find out what went wrong. Discuss with supportive colleagues or seniors what you could have done better. So this is the right way to go about with complications. Thank you.
Thank you, Dr. Raki, for those wonderful insight. Now I request Dr. Aditya Joshi, Senior Cataract Surgeon and Phaco Trainer at Amita Eye Care, Tiruvalla, for the talk, Tips to Conquer Surgeons' Initial Challenges with Grace. Over to you, Dr. Aditya.
Good morning, everybody. I would like to thank KSOS Organizing Committee and Dr. Raki for giving me this opportunity to present this talk over here. I'll be talking about the challenges what a beginner gets during his training time. Like I was also a beginner at some point of time, and I used to face all these challenges. But I was fortunate enough to have Amita madam and Varghese sir with me who taught me all these things. So let me share all those experiences with you. No financial interest. I'll be talking upon these points: clear corneal incision making, sculpting, chopping techniques, the phaco-dynamics of sculpting and chopping, dynamics of quadrant removal, epinuclear removal. So before a surgeon comes to a actual case or on a human eye, he should have a very good wet lab practice, as everybody told earlier. He should know all these things like IPD. He should know his microscope, what he is going to use, the foot switch. A good posture for the surgery is also very important. As a beginner, we should always give a good, adequate local anesthesia so that you can perform your surgery most efficiently and with a calm. Know your phaco machine well, know the phaco dynamics, and as told earlier by all the speakers, that record and always assess all your surgical videos with your seniors. So I'll go step by step. First is a corneal incision making, the clear corneal. As you can see over here, the beginner is trying to make the clear corneal incision, but the globe is little softer and the hold with the left hand is not that good. So the globe is rotating to the other side and the surgeon fails to make a clear corneal incision over here. So what we can do is fix the globe very well. Chamber should be tight, and with a sharp keratome, it should be a ideal 3-planar or a biplanar incision. You can say the surgeon goes, in the inner incision, there is a dimple what we have to create. Go inside straight and come out in the same fashion without extending the incision elsewhere. Next step is hydrodissection. First we need to remove whatever the extra viscoelastic is there in the anterior chamber. Then go underneath the anterior capsule, lift up the anterior capsule and then inject the fluid without forcing it. It should be a gentle procedure. Sculpting. For sculpting, what we need to do mainly is get rid of the central hard core of the nucleus. So the power should be more, but vacuum and flow rate are bare minimum, because we don't want any holding over here. We just want to get rid of the hard part of the nucleus. When we trench, the angle of attack of the phaco tip, or the direction in which we trench, should be according to the contour of the nucleus. The nucleus is deepest at its center, and in periphery it's quite shallower. So if we trench deeper in the periphery, there is a good chance that we will hit the PC and get a rent at this point of time itself. But if we don't trench in the center well, we will have a harder portion of the nucleus remaining in the center, which may not crack, and we will have an inappropriate crack. Again, when we crack the nucleus, the instrument should lie as deep as possible on the floor of the trench. Then only the crack will be better. If you are anterior, the crack will be halfway, or it will cause more stress on the zonules. So this is how the cracking should be. For chopping, you can see over here a surgeon is trying to get a hold into the substance. He tries to get a buildup of vacuum, and even the chopper here you can see doesn't go till the depth of the nucleus, and hence the chop is not coming very well. Somehow the surgeon gets a separation, but it's not all the way through. So what he does next, he goes to another part of the nucleus, tries to get a hold, but the phaco energy used here was additional as compared to what the density of the nucleus was, and finally ends up eating up the piece rather than getting a good hold. He goes to another area of the nucleus to get a hold, but this time he loses its foot switch control, and by the time he tries to hold and get it into the anterior chamber, the piece is lost again back into the bag. So what to do? Here you can see a better holding pattern, but the phaco tip is not totally buried into the substance, and even the chopper you can see the tip of the chopper. That means it is obliquely held. It is not reaching the depth well. That's why the chop did not happen well. So what to do? You have to dig deeper into the substance of the nucleus. The chopper should be lying vertically oriented. It should go all across the depth of the nucleus, and then you can get a good horizontal chop like this. It's better to use a burst mode for chopping with a high vacuum settings like 300 to 400 mm of Hg and a flow rate of around 30. For quadrant removal, as we see, first we have to separate the pieces either by a horizontal or a vertical chopping, or do a divide and conquer. And once we get the separate pieces, we should go to the depth of the cone of that quadrant, in say around 2/3 depth, get a good hold. Once there is occlusion sound, get that means the vacuum is developed, get the piece into the pupillary plane, and then release the full energy, so that with the followability, with your good flow rate, the piece should come out, get emulsified. So for quadrant removal, what we need more is a vacuum and a good flow rate. For epinucleus removal, what we need is minimum phaco energy, but more of vacuum and flow rate. So just go closer to the epinucleus area, which should be free and not attached to the surrounding bag or the cortical area. It should be free. If a good hydrodissection is done, we will have a better epinuclear clearance. So this is how the epinucleus clearance should be done. For cortical aspiration, it's most important, because after doing a good surgery, if we get a PC rent at this point of time, it's too bad. So what we should have is a irrigation. As you can see, the two irrigating ports are on sides horizontally, but the aspiration port is facing upwards towards the endothelium. Go under the anterior capsule, under the cortex, get a good hold, get the piece back into the anterior chamber, and better to aspirate the cortical matter into the anterior chamber rather than aspirating it closer to the bag or closer to the PC, because a surge at this point of time can cause a rent again. So the message is surgery is both science and art. So learn the basics of basic science of surgery, and you can then develop your own art of doing it. Do not get panicked or depressed by any complications. Stay calm, reassess your videos, and then later on you can rectify your mistakes. so that you don't do them again. Doing basics right will boost your confidence, and then you can accept more and more surgical challenges in future. Thank you.
Thank you, Dr. Aditya. That was great videos and great tips from you. So next we are fortunate to have a great surgeon with us, Dr. Amita Verkis, who is the director of Eye Microsurgery Tiruvalla, and she is also running a very good Phaco fellowship there. So she'll be talking about seasoned insights, wisdom from senior surgeons on navigating patient experiences. Over to you, ma'am.
Thank you, Dr. Rakhi, for giving me this opportunity, and I thank KSOS also for being here today. Good morning, everybody. I'll be summarizing today's instruction course with some insights as a trainer. So most postgraduates after passing out MS ophthalmology want to learn most postgraduates after passing out MS ophthalmology want to learn phaco surgery. They feel knowing phaco makes them a better ophthalmologist. My talk consists of two parts, the trainee perspective and the trainer's point of view. Most of the points have been covered. I'm just summarizing the whole thing. To become a good phaco surgeon, before progressing to surgery, a trainee should master basic microsurgical skills, have good knowledge of anatomy and physiology of the eye, learn surgical steps, IUL types and power calculation, machine settings, pre-operative patient assessment, and operative and post-operative complication management. Most of the conferences have exhaustive sessions on phaco surgery for beginners. Attending these courses is helpful to get useful tips. Numerous surgical videos by experts with steps explained are available free on the YouTube, which can be helpful, and also you can borrow videos from your friends and from your seniors. In the wet lab, learning the initial surgical steps on GoTie is an excellent way to learn the various steps of SICS, suturing techniques, bimanual hand-eye coordination, familiarizing with the microscope, phaco machine and surgical instruments, and then to convert to phaco steps. Transition from wet lab to real surgery gives you more confidence. Most of the centers provide wet lab facilities. At our center, trainees start practice on the GoTie first. Nowadays, learning surgery with simulation equipment is also possible. Record your surgical videos, have video analysis after the surgery, and ask for feedback from the trainer. Analyze your mistakes, learn from them, and make sure it does not happen again. Record the data in a logbook. Difficulties encountered can be discussed. The most important step is to find a trainer. The trainer should be following a standard method of surgical steps for training. Now comes the most important question for the trainers or the expert surgeons. Should we train? Training is important to create a good surgeon. No training today, no surgeon tomorrow. During the COVID-19 pandemic, this was a rallying point on social media, calling upon surgeons to prioritize surgical training during the pandemic because the pandemic resulted in a significant surgical backlog. Training cannot take a backseat if we have to maintain a safe and effective workforce. There is a growing demand for phaco surgeons globally. Only by prioritization of training will the profession continue to meet the increasing demand for safe and suitably qualified phaco surgeons. The trainees should know that there is more than just learning surgery. They need to acknowledge the learning curve, know patient communication skills, patient safety, and their own limitations. There is need to emphasize that repeated practice is necessary for mastering a technique and should be encouraged to be updated with the latest trends. I'll now present one of my surgical videos, but before starting surgery, I have ensured that the patient is lying comfortably with the vital parameters stable, the head is positioned properly. I have also checked the machine parameters and the IOL which is going to be implanted. While watching this video, you see how simple it appears to do a phaco surgery. But it's not that easy as it appears. To become a good phaco surgeon with excellent outcomes, you need to work hard on each step of the surgery and improve every day to progress. It's not something which can be served to you. You need to learn and master the steps and make them repeatable to perform standardized surgery. As a new surgeon, you have to be a toughest critic of yourself. You don't need to be praised all the time. You need to be told text. As a new surgeon, you have to be a toughest critic of yourself. You don't need to be praised all the time. You need to be told that you need to improve on your incision, your axis is not adequate, or you are not using your left hand in the right way, or that you need too much phaco, or you have used too much phaco energy. All this should not be taken as a criticism, but as suggestions for improvement. Your mentor knows you can be much better than what you are. Many trainees complain and are frustrated that they are not getting to jump onto the phaco steps or not being allowed to proceed to phaco procedure. The reason is that your mentor knows that you have not perfected the other steps yet. So you have to be patient and sincere. Stop it. A video അങ്ങോട്ട് പോട്ടെ. ആ അല്ലല്ല വീഡിയോ അവിടെയല്ല. സ്റ്റോപ്പ്. ഓക്കെ, ഇത് മേലോട്ടാക്കാം. ഇത് ടെക്സ്റ്റ്. ഇവിടെ ഇത് ഓക്കെ ശരി. വീഡിയോ അത് നെക്സ്റ്റ് സ്ലൈഡ് ആയിപ്പോയി. Anyway, it's okay. So I couldn't complete that video, but the trainer should maintain an environment for learning, ensure safe and effective patient care through training, guide the trainee to build confidence without arrogance, and help in his personal and professional development. He should be a critic of the trainee rather than always showering praises. Should be able to dedicate his time for the training. All surgeons can be trainers if they wish and have the willingness, opportunity to make significant impact on the training, education, and development of junior colleagues. Thank you.
Thanks a lot, madam, for those insights. So now we'll move on to the panel discussion. We have a great set of questions which are usually faced by the beginners in cataract surgery. So today we are fortunate also to have another great surgeon with us, Dr. Ashish Kurula, who is a senior surgeon at the Aradhana Eye Hospital, Trivandrum. So let me first ask the first question to you, sir. So even after being a fellowship trained surgeon, a surgeon is facing back-to-back complications and his confidence has hit ground level. What should you do next? So I'll repeat the question again. So even after being a fellowship trained surgeon, one surgeon is having back-to-back complications in his early career and his or her confidence has hit the ground level. So what should be ideally done next?
Yeah. So this can happen to everybody. It doesn't have to happen during your initial period. After you've got a lot of experience also this can happen. You can have back-to-back complications and you'll be wondering, what did I do wrong after doing so many cases? So it's not just for the juniors alone. But what you need to do is to go back and analyze your surgical steps. This is what you need to do. On the moment when you're doing it, you may not realize what you're doing wrong. So it is important to kind of visualize the steps, and really even at this stage, even seniors, more seniors also, it is very useful to go back and look at our steps and to make out whether you're doing anything slightly different from what you thought you were doing, and that will really help you to move ahead. That is the only way you can prevent the same thing from happening again and again. And the steps which you thought were comfortable, you may be casually doing it, and then you can have a complication there. Steps which are harder, you may be taking more time and finding it difficult. Always, for all surgeons, it's not the same. Some surgeons find certain steps more difficult than others, and you may be finding those steps easy, and you might be finding the other steps hard. So it is a personalized thing as well, but always go back and look at your videos. That's what I would suggest.
So my next question is to Dr. Varghese, sir. So a junior surgeon is having an intumescent cataract. So what is the best way to go for a beginner? He or she should do a phaco or should try to do SACS only? From your experience, sir.
From my experience, they should start with SICS. That will be best. Practice your capsulorhexis on in SICS. Then later on, you can do the same thing in a phaco.
Next question is to Dr. Aditya. So while the surgery, there is a lot of chatter and fumes happening in the anterior chamber. So what are the measurements to be taken to proceed with a safe phaco surgery?
Chatter as such means the things are flying away. They are not coming to the tip of the phaco tip. So that means either the power is more as compared to the density of the cataract, or our flow rate is not well. I mean, the pieces are getting emulsified, but they are flying away because the flow rate, because for a beginner usually the flow rate and vacuum settings might be on a lower side. So the things might flow away. So if we improve the flowability by improving the flow rate, probably the things will fall in place.
So to improve the flow rate and to check the power setting again. So next question is to Dr. Amita ma'am. So when should one upgrade oneself to start premium IOLs as a new cataract surgeon in the field? What is the ideal time to start doing premium surgeries?
So once you've learned your basic cataract phaco steps, and you kind of done, you feel confident enough to do a good phaco, then doing premium IOL is not a big deal, because basically you just have to know which IOL, how is it to be implanted, like whether you need to load it, or if it's a pre-loaded, how do you open up the injector, how to close the injector, where to put the visco. You kind of do a rehearsal before, learn it when others are doing it. So basically that is the main thing, because different premium IOLs will be having different ways of injecting and implanting. So that is the only part which you have to learn. So once you are good enough to already know how to load a ordinary foldable IOL in the injector, then premium does not become a very scary thing to be done.
Next question is to Dr. Ashish. So when can one start practicing hydroimplantation as a new surgeon?
Yeah, I think when you're after you've done about 100 cases, you should be ready to do hydroimplantation actually. But really, there are so many surgeons who don't do hydroimplantation also. So it is not something that you have to learn, but it makes things a lot easier if you can get away with not using visco at the end and doing a hydroimplantation. So you have to be confident with all the steps, and also know your phaco-dynamics quite well, and how the irrigation port acts as you are injecting the IOL. So try it once or twice. If you're uncomfortable, that means you're not ready. So that's basically all there is to it. And as far as what ma'am was saying about the premium IOLs, I think it is a mindset. Our mindset, more than anything, it is a brain game. And if you're psychologically okay, you shouldn't be sitting and thinking, what will the patient say, think, is this good enough, and all those sort of things. And if it is a clear-cut 8mm NS2 cataract, just treat it as a routine case. I would say that will be the best advice to anybody who wants to do. There's nothing fascinating about that surgery. It is exactly the same. Just do the steps perfectly. Concentrate on each step. Do everything perfectly, and then you'll get away with it. Of course, when it comes to complicated cases and you want to put in premium IOLs, that's a different ball game. That probably you need a little bit more experience to get consistent results.
And for a junior surgeon, when can he start doing direct chop techniques? To Dr. Ashish Gupta.
Yeah, so this is what one of my senior colleagues told me, Dr. Shibu Varki. He works in Trichy. He told me he's a very high volume surgeon. And so he said, just in a couple of months, once you reach that 1,000 level, you go ahead and start. I was like couple of months 1000 level. So so it varies depending on how many surgeries you're doing every week or every month or whatever. But I would say once you're very comfortable with doing the hemi chop and doing stop and chop, then you can proceed to doing the direct chop methods, and very convenient to learn the vertical and horizontal chop, and it's definitely useful in different times to use each one.
The next question, when can the junior surgeon stop referring the complicated cases like posterior polar, rock heart cataract and start doing by himself? Dr. Aditya?
I mean, posterior polar cataract as such requires a lot of skill, I suppose. I mean, if he's very much confident enough to go ahead with his skill, and if he doesn't have a backup, better not to touch. If he has a backup, probably he can go ahead once he has mastered his basic training.
So I think you need to be comfortable with your anterior vitrectomy. If you're doing PPC and you're doing rock hard cataracts, you should have, like he said, backup lenses also should be there, 3-piece lenses. Also anterior vitrectomy, you have to be pretty confident to do it yourself. If you're not ready to deal with the complications, then better not to go ahead.
So there is another scenario. A young surgeon is loading, and in the AC he has found that there is one of the haptics are already broken, but he is in the AC with the other haptic inside. But he is not yet confident with the IOL cutting within the AC and also with the proper vitrectomy. So how to prevent and how to manage at a beginner level?
First, if you have backup, better such cases seniors handle. But if you are alone and you have stuck up with this situation, probably I would, as you are saying, it's halfway through, probably the IOL is in the anterior chamber. If it's possible, I'll first inject a viscoelastic from side port so that the chamber becomes stable first, and then once the haptic is cut, maybe it will be halfway through. I mean, some part of the optic has gone inside, the IOL has gone inside, some gets stuck into the injector. Release it, then make the chamber well, coat your endothelium also if possible, protect the endothelium, protect the PC, and then if it's a very beginner, probably he can extend the incision, take out the IOL, then load another new one, implant it, and if required, suture the incision, because once we extend, it will be a leaky wound probably. Or make an SSS incision, scleral incision elsewhere, take out the IOL and then put again. Or if it is a very skilled surgeon, can do the cutting of the IOL, but it is little bit tricky, I suppose, to cut the IOL inside the anterior chamber.
Yes. So one last question to Dr. Varghese sir. So this is a junior surgeon who is still practicing, but he has got a soft cataract. So he has actually tried chopping, and during this, what happened is he has created a central bowl-like thing, and he doesn't know how to go about next. What should be done?
What I will do is I will do a hydrodissection again and bring the nucleus into the anterior chamber and emulsify. That is the best thing to do. You can hydrodissect again, just use a hook to bring it to the anterior chamber and do your emulsification.
Dr. Amita ma'am, so they have become a little more confident. They are okay with the normal cataract surgeries, and they have started doing premium IOLs also. But they want to upgrade themselves to toric IOLs. So what tips you would like to give? When to start and how to practice before going to the OT?
Well, they can practice. One way is that you can start marking the patient, even though the patients don't need a toric. For those patients also, we should start practicing how to mark the 180-degree and the 90-degree mark. And once you feel confident about that, then maybe you can start, when you do, even if you're doing it on an automated system, you do the manual method of marking and keep the manual marker on the, when you're doing it on the table, operative time to correct the axis marking and all that. You start doing it, you can do it under supervision first, few cases with the senior with you, and then it becomes easy. It's not difficult. The marking should be learned properly, basically. 180 and 90 degree, that marking.
Any other questions from the panelists for the junior surgeons? Anup sir is there. Any comments, sir?
Regarding you said, no, when you have done your fellowship and after that you have a lot of problems, back-to-back problems. The thing is, fellowship doesn't mean that you have become top of the, you're not the boss in that field. It is just an introduction to that area. Suppose you have done a cornea fellowship or a phaco fellowship, and it depends on which place you have done, how many surgeries you have done, because in some places you hardly get any surgeries, some places you may get huge number of surgeries. After that also you have to work, you have the license to work in that area, and then you have to do a lot of surgeries before you become, you can truly say that you are confident and you are a boss in that area. So till that time, you should not have an ego that I have done a fellowship, I am the boss in glaucoma. No, there is still, you take lots of years for you to really reach to that level. But the thing is, many people after that, they just go plateau. Actually, that is the problem. What happens after fellowship, they will do few cases and they will keep on doing the same things. Like say a glaucoma, they will just keep doing the trap and they don't want to go to the next step, like doing MIGS. So there are so many things which are coming out. So you have to have that mentality to keep on progressing. Then only I think over a period of time you will reach the top. Complications everybody will have, but this is what is my opinion on that. Thank you.
So, any cutoff numbers after being a junior surgeon, when you should actually start?
Actually, numbers don't matter. Just like Dr. Anu said, numbers don't matter. You have to keep on and on.
So, I think any other questions from the audience? Any questions to the panelists? Any doubts that you have as a junior surgeon? So I think we have come to the end of this session. We had a fruitful discussion also. Thank you everyone. So let's just have a group photo.